Good afternoon, ladies and gentlemen. I'm Dr. Manoj Sharma from Delhi. I'm going to talk about percutaneous transforaminal endoscopic lumbar discectomy today. Future of spine surgery is in minimally invasive techniques, and we should try to bring these procedures in ambit of our armamentarium. Endoscopic spine surgery is a burgeoning field of MIS. Besides soft tissue sparing and early recovery, one more reason is increasing pressure of new generation to market their practice in educated consumers. This is a very interesting editorial 5 years back by the Who's in Spine of America, breaking through the glass ceiling of minimally invasive spine surgery. They had predicted that the new technologies and Vista will come up, and by 2020, about 50% of all spinal cases will be done by the MIS techniques. And I think they were absolutely fine. In the field of the discectomies, it is even more common. Principles of endoscopy to prevent collateral tissue damage and postoperative complaints and complications. MIS technique developed with goals to minimize disruption of paraspinal soft tissue envelope, limit blood loss, decrease postoperative pain, and hasten patient's recovery. In addition, there is improved cosmesis. Endoscopy is the least minimally invasive spinal procedure. Just for a comparison, you see that on the left-hand side, you've got the open discectomy. In the middle, you've got micro, and on the right, you've got a endoscopic discectomy. The X-ray shows that all the lamina has been knocked off in the open discectomy. In the lateral view, you don't see any posterior element. The spines seem to be hanging in a space. Such type of procedures have got no place in the modern surgery. We have got no right to destabilize the spine for such a small work. Even in the microdiscectomy, we may have to damage or require removal of the normal anatomical structures. Like we have to do the paraspinal muscle retraction, which can denervate the muscle, removal of the ligamentum flavum, joint capsule, medial fasciectomies, laminotomies, besides manipulating the nerve root to access the disc. Because the disc is the most anterior structure, and this is a posterior approach for an anterior structure, which doesn't sounds very logical. So it has got a tendency, it can destabilize the spine and cause postoperative backache. In special conditions like foraminal and extraforaminal disc, endoscopy is a cakewalk, whereas micro is a difficult option. Second surgery at the same level, again the same. Can we further reduce the recovery time and return to work? Yes. Endoscopy doesn't damage any normal structure. What about the patient declared unfit by our anesthetist? Our procedure is done under the local anesthesia. We don't want their referral. So the transforaminal endoscopy is done through the foramen. Foramen is pretty wide in size. If you see it here, it is 12.3, 8.9, and 23. So our endoscope working cannula is just 7.5 or 8 mm, and here the size is pretty big. This triangle, which is called a Scammon triangle, is bounded laterally by the exiting root, medially by the traversing root, and inferiorly by the superior end plate of the inferior vertebral body. And the only important structure here is the nerve root, which goes out along the pedicle, and generally it doesn't come in our way. This is a very important study by the Markovich about the dimensions of the foramina. This was a cadaveric study on 96 foraminae. And according to him, it is pretty safe to introduce an 8 mm cannula at the mid pedicle or the medial pedicular line level. Indications would be discectomies for every location like the extraforaminal, lateral, central, migrated disc, lumbar canal stenosis like foraminal, lateral, or the central. Now we do the lumbar spinal fusions, discitis, facetal cyst, annuloplasty. This is the endoscope which I use. It is the Karl Storz 25-degree working cannula of 7.5 mm. It is a continuous irrigation, and the working channel is 3.6 mm here. Although in the market, you've got other endoscopes from 0, 20, 30 degrees made by the Wolf, Maxmore, Thesis, Chinese companies, Indians. Matrix in the descendo system is the interlaminar system. We are not talking about that here. We're talking about the transforaminal systems. Now here, if you compare, the latest endoscopes have got a big working channel, which is 4.1 here. So the stouter instruments are used where the damage chances are less and the job can be done faster. Regarding the endoscopic instrument, the graspers, cutter, they are more or less like the microdiscectomy instrument, except that they are long and slim and delicate. The basic instrument is an 18-gauge spinal needle, a guide wire, a dilator, and then a working cannula with a bevel tip or a round tip, and our endoscope. Then we might require reamer with the manual or otherwise for the tight foramen, like in old age where there are lots of osteophytes. But the disc disease is a disease of young age, and generally we don't require it. Then we've got the radio frequency cautery. The laser and other instruments are used for the advanced technique, but in India it's not popular. The burr works much faster and much cheaper. Now, just to show you, I am using a laser for cutting the bone and the soft tissue and hemostasis. So this is a surgery done under the local anesthesia over the radiolucent table under the C-arm. The conscious sedation with the midazolam and fentanyl is allowed, is given for the continuous feedback. For the left-sided disc, the surgeon stands on the left side. Everything else is on the right side, like the monitors, the C-arm, the assistants. The most important thing is doing some, you have to make some lines in order to find, you just have to, under the C-arm, you have to locate the level of the disc, both in AP view and the lateral view. And then you have to see the entry point. The entry point is actually according to the location of the disc, because our aim is to go to the base of the extruded disc. The most common disc is in the lateral recess, so that our point, our aim is to go to the mid pedicle or the medial pedicle line. But if the disc is central, then we have to go more horizontal. If the disc is lateral, like if it's an extraforaminal disc, then we go vertically down. So for generally, we start posterior laterally at 12 centimeter. For the extraforaminal, we start about 7 to 8 centimeter lateral to the midline. So the first thing is we give a local anesthesia, and then we put in a needle and the guide wire. The most important step is putting the needle in. If the needle has been placed perfectly, 80% of your work has been done. So where it has to be? For the lateral recess disc, it should be in the mid pedicle line in the AP view and in the posterior vertebral line in the lateral view, because this is where the extruded part is. So a little planning is required in the C-arm, that where exactly how to go to the base of the disc. Then over the needle, we just pass a dilator, which can be hammered in, and then the cannula. And then our endoscope is ready with the continuous irrigation. Now, just to give you an example, this Ritu Bajaj, she's 30 years old, and she's got a left-sided pain. She's got a lateral recess disc. And the endoscope, you see that the working cannula in the AP view is in the mid-pedicle line, and in the lateral view, it is lying half into the disc and half in epidural space. This is just a small video. For a huge disc, we may have to take the complete endoscope out because it is so big that our working channel is only 4.1 mm, like in this case. And the patient is watching the procedure done on the monitor. The procedure is very safe because we see 20 times magnified view, and the patient is talking to us. So if we are touching her nerve, she will tell us that she is feeling pain going down the leg, and also she will alert it and make the things more easy for us and safe. This is another patient done long time back. This was done in 2003. We were using indigo carmine dye to stain the disc. So you see the disc is blue in color here. And on the top at 12 o'clock, you see the epidural space. This is the traversing nerve root. And so we grab this fragment and remove it, as you can see it, and decompress the nerve root. And this video I've just shown you to show that the patient was awake, as you just saw. And when we remove the working cannula, it is just a small hole, and it closes on its own. Just a band-aid is enough, but we use a single stitch. Now, this is in case of the foramina is tight, we may have to use the burr, like in this case. It is just for a demonstration. The disc has been removed, and then because the foramina is coming in the way, so this is a burr, as you can see that. So we have to trim the facets in order to reach more medially. So this is the preoperative sagittal image on the left side. On the right side, you see that the disc has been removed in the postoperative image, same in the axial cuts. Just a single stitch. This is a neurosurgeon. He's a head of department in Kabul. And he had come down all the way from Kabul to get his discectomy done by the percutaneous endoscopic technique. So this technique is being spread all over the world, and obviously it is the most minimally invasive way to remove the disc. There are lots of comparative studies with the microdiscectomy, with open discectomies, with the interlaminar destendu and other techniques, with a transforaminal technique. And it has been seen that the transforaminal technique is very safe and effective, a very successful technique, and the early recovery and the early results are much better. Although after a year, they might be the same, but it is the most minimally invasive way to do a thing without damaging the normal anatomical structure. These are some of the pioneers like Dr. Loy, Dr. Loy from Switzerland, is Dr. Martin Knight, UK, Rutan and Comp, Germany, Dr. Thomas Hoagland. He is no more with us. He had designed the thesis system, the Max Morris copied that. And this gentleman is the Sango Lee, the owner of the Wuridul Spine Hospital, Seoul, a very rich guy. Most of our doctors go and get their training there at his institute. And finally, we've got the master of them all, the one who started it way back in 1999, the real pioneer, Dr. Anthony Young from Phoenix. I'm really lucky that he's my friend, and he is turning 80 now, and we are going to celebrate his birthday the next week. So, ladies and gentlemen, thank you very much for your patient listening, and have a good night. Bye-bye.